Hi friends, welcome to Coffee with Ravi. This month, I wanted to talk a little bit about inflammatory bowel disease, which consists of Crohn's disease and ulcerative colitis. Inflammatory bowel disease is a condition where the body's immune system, which typically is a part of our body and it's in our blood, in our bones, in the gut, which fights off external infections or infections that get through. But in case of Crohn's disease and ulcerative colitis, the immune system targets the body's own system, in this case, the gut. There can be some extra gut manifestations too of this condition called extra-intestinal manifestations, which can involve the liver, the skin, the eyes, where there's inflammation of the white of the eye, etc. So called uveitis. Not white of the eye, but rather the part of the eye called uvea. So all of these can go along with inflammatory bowel disease, and that is what we call an autoimmune condition. The main difference between Crohn's and ulcerative colitis is that Crohn's disease can affect the entire gut. So it can affect the stomach, it can affect the small bowel, it can affect the colon, whereas ulcerative colitis is predominantly or only the colon. That's the main difference, and there are many other smaller differences, but the broad starting point for understanding the differences in terms of inflammation, etc., is the area involved. Of course, there's some minor nuanced differences in that in Crohn's disease, the inflammation can be more extensive and can go through the entire wall, whereas colitis may not be as extensive, but those are just kind of in reference somewhat relative differences rather than absolute differences. But the only one is that the area of involvement is very clear. In other words, with ulcerative colitis, it's only the colon, whereas with Crohn's, it can be the entire GI tract. The other aspect that I want to bring to bear is that there's a condition called irritable bowel syndrome. Irritable bowel syndrome is very different from inflammatory bowel disease. Irritable bowel syndrome is more a problem where there is a movement of the gut, or how the perception of the movement or spasm of the gut is felt by the brain. So it's more of a non-inflammatory condition, whereas inflammatory bowel disease, which is more a body's own immune system inflammation than a non-inflammatory condition. So that's the main thing. Treatments are different, goals are different, etc. Both can be challenging sometimes, but perhaps inflammatory bowel disease is a bit more of a serious condition. There are many other symptoms that sometimes we try to take into account other than just the actual inflammation. There can be fatigue, there can be joint inflammation like I talked about, there can be extra-intestinal manifestations, and there's a whole host of things that can go with it, which can include anxiety about the disease, sort of the loss of quality of life when there's active inflammation. All of these can go into adding to not just the gut inflammation, but the whole disease process itself. The other piece that can happen is that it's hard for people to understand the whole picture of what's going on. So there is a little bit of that, how a patient with colitis and Crohn's fits into society as a whole because of that understanding or lack of understanding sometimes of any disease process, particularly in this case, inflammatory bowel disease. The good news is that the treatments in this condition have grown leaps and bounds. The goal of treatment is to decrease the inflammation or take the inflammation back to a level where the body can heal itself. There's four mainstays of this. Number one mainstay of this is prednisone or steroid type medication. This has been the go-to and still is the go-to in the acute setting. If somebody comes in with acute inflammation, these are very effective medicines that can put the inflammation down in the great majority of cases. There are a small segment where people don't respond to prednisone or prednisone-like medicine, but that's very small. However, long-term treatment is not something recommended with prednisone-type medicines because of side effects, can cause cataracts, blood sugars can go up, skin can become thinner, bones can become thinner, those kind of things can happen. So the goal is to try to get somebody off steroids if we can. And very, very small percentage, we tend to leave them on a very small dose of steroids, but that's also very uncommon. The second group of medicines that we use are medicines that work with the immune system. One group is called Imuran or azathioprine. It's a medicine that's been there for a long time. Decently effective, it has its own side effects, can occasionally inflame the pancreas, can decrease the bone marrow production of white cells and red cells, can cause pancreatitis or inflammation of the pancreas. But in general, has a lot of experience with it, can be about 20 to 30% effective as a whole in decreasing the inflammation. The next group is a group of medicines called biologics. In inflammation, the immune system releases several messengers that can go and cause the inflammation at the gut level. So these biologics act at various levels to either mop those inflammatory bullets, so to speak, or to decrease them, or to take them out of action. And we've all there's many of them, and we are familiar with them, such as infliximab or Remicade, Stelara, or Entyvio, or these are brand names that I'm using, but these are in the broad range of medicines that are in the biologic range. Last group of medicines that can be used as adjuncts are the 5-ASA or mesalamine type products. These are ones called Lialda, etc. They can be used in conjunction, sometimes used alone to keep people in maintenance if it's mild, but can sometimes be used in conjunction with these other medicines to keep the inflammation down and controlled. The role of diet in inflammatory bowel disease is interesting. Typically, there is no one diet that can cause for the inflammation to go down, because in other words, a fire has already started. But a Mediterranean type diet can help people who have gone into remission. Remission is a word that we use where the inflammation goes down, the symptoms of diarrhea, blood, etc. go down, and it can keep people in remission. We also recommend that if somebody is having an acute flare, or if they have some narrowing of the small bowel, etc., that you can go on a low fiber diet during those flares, especially for people with Crohn's. And there's a whole range of diets called elemental diets, which are very specific, which we'll not get into, that may be helpful, that have been shown to be helpful, but certainly not in widespread common practice for clinical use on a day-to-day basis. Some patients say that there can be some specific food triggers, and we need to respect that. And I think if there's a particular food that you can feel is not agreeing with you, certainly while we don't understand the mechanism, the foods have a lot of antigen, or they have a lot of their own characteristics. So we certainly don't understand every aspect of how food interacts with the gut. A Mediterranean diet has a good base of fruits, vegetables, and legumes. Legumes are beans, etc. The Mediterranean diet, as is classically defined in medicine, there's use of olive oil and less of any other oil. Nuts are a good part of that. Fish and poultry are part of that, and there's limited red meat and limited processed meats and processed foods in that diet. So that seems to be helpful, and it seems to be helpful by decreasing the inflammation in the gut. So therefore, in general, not just for this, for many other conditions, heart-related conditions, etc., the Mediterranean type diet seems to be the go-to these days when you look within the traditional aspects of medicine. So my key takeaways are that I think inflammatory bowel disease is a condition where the immune system tends to irritate the colon and small bowel and other areas. There can be extraintestinal manifestations. Treatment is effective, where our goal is to try to get the symptoms into control, symptoms of diarrhea, blood, bleeding, abdominal pain, etc. The fatigue aspects, all of these to be improved. Our goal is to improve the gut healing so that endoscopically everything is healed. It is very much manageable and very much a thing that can improve the quality of life. And I would encourage conversations with your gastroenterology provider on this. This has become a very niche area, and it's important to keep thinking about different medicines, the goals, and how we even put this diagnosis together, because it can be a very refined diagnosis based on the symptoms, based on the endoscopy, based on the pathology, that you have to build the diagnosis itself. So please make sure that that diagnosis is nailed right, because it can be a lifelong condition, and therefore important to make sure that your gastroenterology provider has really put that attention in and thoughtfulness to make that diagnosis. So thank you for joining me today. As always, if there are questions, please email or send us those questions and we'll try to get back to you. Thank you.